So basically the title of this is Cardiology in the Time of COVID. And I take a lot of pictures, not all of them with my camera. A lot of them I take from elsewhere. And I would say that I'm a literati, but I'm really not. My wife is, but I'm not. And I'm in the process of reading Gabriel Marquez's book, Love in the Time of Cholera, which some of you may have read. His more popular book is 100 Years of Solitude. And it sort of ties in because we've all been through, to some respect, 1 year anyway of solitude. But as you'll see, this talk is far-ranging, a lot of philosophy, a lot of helping you deal with conceiving what's going on in the world for the last 18 months, getting over the ongoing PTSD that we've all experienced at one level or the other, personally, professionally, and on. But anyway, so if this is a little bit different than all the other stuff you've got, good to meet you. I'm Dr. Boogaerts. So this is a picture I took of the Grand Canyon the first time I went there, 2005. The backstory on this is, for whatever reason, I was on the compliance committee for our group, Cardiovascular Associates, at the time, and the meeting was of all places in Las Vegas. Now, why you'd have a compliance committee meeting in Las Vegas, but that's where it was. So I had my son, my youngest son, who fly there and meet me after the meeting, and we drove from Las Vegas to the Grand Canyon to hike down, and hiked all the way down to the Colorado River, then hiked all the way up. That's not the way to do it. The way to do it is hike all the way down and spend the night halfway up and then come up. But anyway, we drove, if you drive from Las Vegas to the Grand Canyon, you drive over the Hoover Dam, but it was like 2 in the morning when we were driving over Hoover Dam, so I never saw it. And then when we arrived at the Grand Canyon, it was totally socked in. It was fog, it really maybe 40 feet of visibility. And yet I took this picture. So the next slide shows what it looks like, what it looked like, and you could not see anything. And there's my son sitting there, and he's done a bit of backpacking. He said, "It's the worst trip I've ever been on. Can we go back?" And we were in about, half a mile. And I really thought, I said, well, we'll probably never see anything. Maybe we should. You're always tempted to drive out and go just hang around, see the big crater, go to the gift shop. But I said, no, let's keep going. And we did. And within 60 minutes, we were looking at that. And we were looking at that. That's halfway down the Grand Canyon on what they call the Tonto platform. And as you can see, it was just spectacular. I mean, everything had opened up and lifted. And the reason I show you this is because we were all in pretty good shape January of last year, and then the COVID hit, and now we're saying, will we ever get out of it? And you have to remember, one of the fundamental elements of reality is what we call impermanence or change. So as good as things are, well, they can suddenly change, and as bad as things are, it won't last forever because nothing ever does. So anyway, that's a little word to remember. And there's the title of the talk, Cardiology in the Time of COVID. There's where I stole the title from. Gabriel Garcia Marquez, Nobel Prize-winning author from Colombia, wrote Love in the Time of Cholera, sort of a complicated love story of a group of people in a small town, turn of the century, 1900 or so, in a coastal town in Colombia. And he's a gifted writer, and I just use his title. So there is Cardiology in the Time of COVID. So first of all, just going through the trauma that we've all been through of quarantine, isolation, this whole isolation event. And again, all of these slides are already uploaded on the website. I'll tell you where to look at them. So if I flip through them and say, gee, I didn't get a chance to read all that stuff, that's not necessary. You don't need to take notes. You don't need to memorize. You can pull it up right now or when you get home and zip through anything you miss. So, we all know this, quarantine, what are you supposed to do? What aren't you supposed to do? We know so well Well, mainly you don't do all the things you like to do for the last 18 months. And sort of emerging right now, but as we have to remember, this isn't the beginning of the end, this is sort of the end of the beginning. And as I sort of put it metaphorically, we're sort of at the end of chapter 1, and it's ended pretty good. We've started chapter 2, and it looks a little shaky. Don't know how chapter 2 will end, and the COVID book might be 3 or 4 chapters. So, that's sort of the fatigue, this ongoing reality that we're all living with. Don't worry, it's going to get to the heart here in a minute. Anyway, so there's the isolation, 1 year of solitude. I thought that was cute. And there, the Nobel Prize winning author, Gabriel Garcia Marquez, 100 Years of Solitude. Basically talking about a small town in the Colombian jungle and all sorts of mysterious things happen. It's a good book that I've, again, worked my way through. So finally, there we got the heart, a nice shot of the heart. And in this talk, I'm going to teach you a couple of words that you use all the time. And there's the coronary circulation. Now here's a prettier picture of the coronary arteries, and showing you not just the epicardial arteries. We talk about the left main coronary arteries, and cardiology is pretty simple in a sense because there are 2 arteries that supply the heart muscle. There's a left main and a right coronary. The left main splits into the LAD going down the front of the heart. The left circumflex goes around the back of the heart. But as you can see, the cardiac muscle is intensely vascularized. Not only are there the coronary arteries, but all these little branch arteries that go into the myocardium to supply the heart muscle with all of this blood supply, oxygen, giving oxygen, taking away carbon dioxide. But the question is, well, why do they call them the coronary arteries? Do any of y'all know why they call them the coronary arteries? And I met one of the representatives out there. It took 4 years of Latin, not from New Orleans where you take Latin, at least back in the late Pleistocene. So coronary arteries are called coronary because back in the day when there were kings and queens, the anatomist turned the coronary arteries upside down and said, well, that sort of looks like a crown. So there you go. How many of y'all knew that that's why they call the heart arteries the coronary arteries? Well, there you go. That's Latin, corona, crown. By the way, doctor is from the Latin docio docere, which means to teach. So I taught y'all something. So there you go. And I'll teach you another word that you use all the time that nobody has any idea what it means, but it's something you use many times every day. And so there you go. They looked at that, they said, well, that sort of looks like a crown. And again, a crown back in the day, when there were kings and queens, and that was something you saw on the heads of special people, as we say. And there's another crown, the coronavirus, sort of with those little spike proteins. But it's not a good crown, it's a bad crown. Now the next slide is kind of shocking because it gives you an idea of the magnitude of the problem. And the magnitude of the problem is that just in the last 18 months, we've lost 600,000 Americans from coronavirus and a number of million humans on the planet. And the reason I show you this next slide is because I sort of have a theory that we can sort of get our mind around about 10,000. And beyond that, it becomes a number. It's a billion, a trillion, a gazillion, but we don't have any concept. But this gives you an idea, and this is a milestone we just passed June the 11th. 600,000 people have died from coronavirus. And that sheet is a sheet with tiny dots, 10,000 dots. And to represent adequately the number of people that have died of coronavirus, 60 pages of that. Or, since all we really care about is SEC football, you fill all of those stadiums full, and those are big stadiums. Those are 100,000 stadiums. Bryant Denny, Jordan-Hare, Tiger Stadium, that I'm a little fond of because I'm from New Orleans and went to the LSU franchise in New Orleans. Anyway, that's how many people have been lost from coronavirus. So it's significant. It's dramatic. It's more than you really think about when you say, oh yeah, 600,000, you know, that's bad. Well, it is bad. And there it is, the cruel beauty. This is, again, Albert Camus wrote this book, The Plague, and I pull this up just because of the quote that's so true, that we forget that every once in a while, big infectious diseases sweep the earth. You know, the influenza epidemic of 1918, you know, way beyond that, the Black Plague, just on and on. It doesn't happen frequently enough that it's always in our mind. So that it was kind of a shock to everybody when, gee, why can't we go do all the things we used to do in starting January of 2020? And it just takes us by surprise, but there it is. And we're still, you know, drifting along in it, waiting for the next wave or whatever we're waiting for. But we all knew that this was a reality from, you know, 1918, but none of us were born then. But anyway, bang, here we are. And again, the coronavirus, if you're a virologist or overeducated, and some of y'all are probably more educated than I am, although I've tried real hard, coronavirus replication is very interesting. I mean, that's what it is. It's a replication machine. You know, there's discussion, are viruses really considered living, you know, because they require entry into a living cell to replicate. And the coronaviruses, and there are a bunch of them, you know, the COVID-19, that particular virus is one of a branch. They're RNA viruses. They latch onto a receptor on a cell. In the case of the COVID virus, it latches onto the ACE2 inhibitors, if you've seen. It insinuates itself into the cell, replicates, and on it goes. And here, this just gives you, and all of these slides, again, are on my website, and you can look at them at your leisure and learn more about, you know, what we're talking about. So the spike protein latches on to an ACE2 receptor. It merges, the wall of the virus merges with the membrane of the cell, and it enters the cell, takes over the machinery of the cell, replicates, and then emits more and more viruses. And again, we sort of think, well, why in the world will this happen? Why is this, all this badness? Well, it's not really good or bad. It's just, you know, here was a virus previously in bats. Bats live in, you know, tiny packed communities. Bats have sort of developed immune systems that can tolerate that, and humans not so much. But suddenly, you know, we've been exposed to a virus that replicates, and it's, you can think good, evil, bad. Well, no, it's just a virus, and it's something we've got to deal with. And so that's where we are. Jumping forward finally to what this has to do with the heart. This is just a nice resource, American College of Cardiology resource about what are the effects of COVID infection on the heart. Now, as you'll see, I'm not going to go into a whole lot of detail about that because we do know that it causes some problems in the heart, but we're still extremely early in this disease to know, well, how much of this is just the effect of a bad pulmonary infection, of sepsis, hypotension, all that stuff. What kind of long-term effects are patients that have COVID going to have, you know, long hauler? Well, we don't really know, and so I'm not going to preach to you with a bunch of information that we really don't know, because it's obviously still evolving, because we're just in this 18 months now. This just is another, just all the information on that ACC website that you can look up at your leisure. It's just some pretty pictures of the heart, front and back. You see the front of the heart a lot. The back you don't see so much, but that's just a nice shot. And here's these next shots are something you don't see very often at all. The heart viewed from the top, or the base of the heart, and from the apex. These next set of slides I'm just going to show you because y'all, as I often say, nurses do most of the work in the hospitals. You know, doctors sweep in and out. Techs do most of the work as well. You know, physicians come in, give a little thought, write orders, and, you know, take off for parts unknown. But y'all hear a lot of information about what's happening with your patients, and a lot of the patients that have severe respiratory illness, including COVID, have troponin elevation. They say, gee, they've had a heart attack. And the patients and the family's all concerned, oh, what's that, their troponin? The good thing about troponin, and I'll show you some images of, the good thing is it's extremely sensitive. The bad thing is it's extremely sensitive for marking any kind of myocardial irritation. You know, it used to be in the old days, you that have been around long enough, we used CPK and CPK-MB, and that was not nearly as sensitive, but if you had a patient that had an MI, or you thought might have an MI, had CPK elevation, CPK-MB, you could pretty much say, well, yeah, that's bad. But troponin can leak out of the heart muscle cell into the blood, be measured, and the patients will maybe not have had an acute coronary syndrome. And I'll just show you a few images of that. So there's your typical sarcomere. This, the statement there is, in acute infection, troponin elevations may rise just because of the stress of the infection. It will be what we call a type 2 MI. You know, they used to call it troponin release, but now it's type 2 myocardial infarction. And this is just some shots of, you know, what does troponin look like. And this is a busy slide. The little purple spheres are actin. That's an actin fiber. The little strands are the myosin. You know, actin and myosin. Troponin is a small protein. There are several types, troponin T, troponin C, troponin I, that are very small proteins. And you can imagine just looking at that with any kind of stress, some of those little proteins may break off, diffuse through the membrane, and be found in the blood, and they may rise to a certain level that would be considered, oh, well, there's been some heart muscle damage. But that's just another slide. But it's different than our standard acute myocardial infarction, type 1 MI, standard ST elevation MI or non-ST MI, which is caused, as you can see in this image, by an atherosclerotic plaque that breaks open. The platelets see that as a break in the endothelial lining, form a little platelet thrombus, clot off a coronary artery, and the patient proceeds to have acute coronary syndrome or an acute MI. That's a type 1 standard MI. Often, as you may or may not know, the atherosclerotic plaque that causes a myocardial infarction is only 50 to 70% stenotic, not severely narrowed. That's why, out of the blue, patients can say, well, gee, I was doing fine, I was exercising, not having trouble, and then a month later I had an MI, or even I had a stress study, I was doing fine, I passed my stress test, and 3 months later I had an MI, because most MIs are caused by narrowings of only 50 to 70%. You say, well, gee, why is that? Well, it's because if there's a lipid-rich area in an artery that's not severely narrowed, it breaks open, the platelets see that as a break in the artery, they'll form a clot that sometimes will close off the entire artery, which would not have had the benefit of gradually slowing down to where you would have had collaterals. That's why, by the way, low-dose aspirin is so effective, makes the platelets a little bit less adhesive, less sticky, and why statins are so effective, makes it less likely that any atherosclerotic plaque contains a lot of cholesterol that would break open, more likely to be a stable plaque. Those two medications, the low-dose aspirin and statins, have made a big difference in acute myocardial infarction, type 1 MI. Now, type 2 MI, and that's what we'll talk about in the context of COVID, as you see, secondary, the big arrow, secondary to another illness or process, might have fixed coronary atherosclerotic lesion. In other words, a lot of patients walk around with a 70% or 80% stenosis in one of their branch arteries or one of their main right LAD circulations. Why don't they know about it? Well, they might not know about it because all they do is walk around their house, walk to the kitchen, walk to their car, go shopping, and never do really exert themselves to where they'd have symptoms. Or if they have symptoms, they may say, well, maybe it's indigestion, maybe it's something else. But if they're in a circumstance where they're all of a sudden have a fever of 102, have low PO2, have a heart rate of 120, septic, they're going to know that indeed they've got a demand, they've got a constant demand on blood flow through that narrow coronary artery, and they may have troponin release due to that. But again, not a type 1 thrombus in their coronary artery MI. Or even in a patient with, and then the top and the bottom show that top artery shows a pretty severe narrowing, but again, that may be in an asymptomatic patient who suddenly has troponin release because of a high temperature, tachycardic, hypotension, supply-demand hypoxemia, and then troponin release, or even in a patient on the bottom with normal coronaries. In other words, you take someone with normal coronary arteries, all of a sudden they're febrile and incessant sinus tachycardia of 120, 130, they could easily have troponin release just due to outstripping the demand of blood supply with normal coronary arteries. So we'll talk a little bit about how COVID-19 affects the heart. And as you know, being a respiratory therapist and having to deal with it, it's primarily a pulmonary, or starts anyway, primarily being a pulmonary issue. This I show just because it's pretty simple. It's stuff we all know, and yet, so it's a virus. It comes out through respiratory droplets, and an adjacent person could inhale those respiratory droplets that contain the virus. And you'd think, well, one way to mitigate transmission would be wearing a mask, social distancing, and yet, as you know, that's been a big problem to get people to comply with that. And now, of course, there are all sorts of other things interjected, and there's such fatigue in not being normal. And everybody says, gee, why can't we just be normal again? Anyway, this is stuff we know. And as y'all know, the virus mainly affects the lungs. You know, as we talked about, a bunch of the other speakers have talked about ARDS and the severe pneumonias that patients can develop. But it can also cause problems with the heart, directly to the heart. Most commonly on things like myocarditis. Obviously, sometimes there can be this thrombotic effect that they've talked about. And this is just showing a prevalence of myocarditis. And again, I don't go deeply into this because who knows what the long-term effects of this are. A lot of patients that develop myocarditis, for whatever reason, get over it without much of a problem. And again, this is a study done in athletes showing a relatively low 2.3% chance of developing a myocarditis. And again, that's part of the problem with COVID is the percentages are pretty low, but yet if you're a healthy athlete and you're part of that 2.3%, it's a big deal for you. And it's just showing you a heart cell that has ACE inhibitors. The virus can latch onto that with its spike protein. It can be taken into the heart cell, replicate, and there you go. And here's something, this is, my wife showed me this, it's just from a couple of days ago, July 12th, talking about what y'all were used to. I presume those of you that worked through the COVID last year, of shortage of ventilators, shortage of supplies. Well, just like ventilators can be in tight supply, ECMO, as great as it can be, and as you know, as you get 100% FiO2, PEEP, and then you're not oxygenating, well, the next step, if you're going to do something, might be ECMO. But the problem is, if there are enough people demanding that, the ECMO will be in short supply, rationed, and then there's a whole issue that again, y'all have to see and deal with. Well, if there are this many patients with COVID on ECMO, there's still the group of patients that have not COVID but may have a severe cardiomyopathy or some other reason to need ECMO, and if there are just so many ECMO machines in a hospital, you sort of have to deal with that whole thing that we're not used to dealing with, which is, gee, we'd like it, but all the ECMO machines are being used right now. So that's sort of one of the reasons why it's important to push for the mitigation strategies that we know, distancing, masking, vaccination, that still, we're having difficulty with in the world at large, in Alabama in particular. I show you this because I have, what I've been doing for the last 9 months is teaching ECG interpretation to fourth-year medical students at UAB. And it's a web page that gives you a lot of information about ECG. A lot of you may find it useful, even if you know more about ECG interpretation than I do, because a lot of your patients have ECGs, and it gives you a nice description of how do you approach looking at ECG, left bundle branch block, right bundle branch block, infarct, all sorts of things that you may find useful. And I put that just because it's such a beautiful picture, showing you that a 12-lead ECG is really looking at the electrical activity, depolarization, repolarization of the heart from 12 different angles. And that shows you what are the 12 different angles, you know, lead 1, 2, 3, RLF, V1 through V6, bang, there you got it. Now, the other reason, this is sort of an entry into some of the things that were done last year, using drugs that we were hopeful might be good. And what was all the hubbub about why they might be bad? Hydroxychloroquine and Zithromax. And again, that was being used, perhaps overused, before there was a lot of data. And it intersects with the heart because both of those drugs can prolong the QT interval. And as you may know, the ECG, pretty simple. There's a P wave, that's depolarization of the atria. There's a QRS, that's depolarization of the ventricles. And then there's a little pause. And then there's a T wave, that's the ventricles repolarizing. And the QT segment is the segment of an ECG between the beginning of the QRS and the end of the T wave. And it's during that time that the ventricle is very sensitive to any extra beat. It's vulnerable to have a bad rhythm called torsade de pointe VT. I don't speak French fluently, but I've learned how to say that. So torsade de pointe means dancing around the point. And basically it's a specific type of ventricular tachycardia where the impulse goes around the tip of the heart, and that's why they call it dancing around the tip. And it's like most ventricular tachycardia, it's bad, because the rate is so fast that the patient would get dizzy, then collapse, and if not quickly resuscitated, likely not make it. But anyway, that was sort of, this is why there was all that hubbub about, well, why use hydroxychloroquine and azithromycin? And sometimes you need to use medicines that may increase QT, but certainly you do it in a very controlled, monitored situation, and not just say, here, take this and see how you do, especially as it panned out, if it was not clear that that would be of much benefit. It's always cost, benefit, risk of any kind of intervention that we use. And again, this isn't big news. This is a list of medicines that can prolong the QT, and there's a long list. Many common medicines that we use all the time can prolong the QT interval. And so that's why it's important to know what medicines is a patient on. Do they already have a prolonged QT interval, and therefore is it safe to give them that? In both hydroxychloroquine and zithromycin prolonged the QT. So that was the whole reason for pause in giving those medicines. Here's what torsade de pointe VT looks like, which is, as y'all have seen, is not real pretty. It's a fast, oscillating ventricular tachycardia. And this leads us into the next thing I'm going to talk about, which is if you have a patient with this, what they need is good cardiopulmonary resuscitation. So there's a heart, and this will show you what ventricular tachycardia looks like. There's a heart having normal sinus rhythm. Those are just conducting fibers in yellow. And then all of a sudden, there's VT, and you can see it's a disorganized contraction. Blood pressure goes from, say, 120/80 or whatever it was to nothing, because basically there's no organized contraction. And if a patient has that, it's very important. And here I'm going to lapse back a little bit into the talk I gave in the last session, which has been 2 years ago, which is how you can give the best CPR to patients who suddenly have sudden cardiac arrest, who suddenly have VFib. And that just shows sinus rhythm degenerating into ventricular tachycardia. And here's the other word that I'm going to teach you the meaning of. And nobody that I've asked knows it somehow, because they didn't take Latin, I guess. They always say, oh, it means you got to wait. They say it's patient. No, it has nothing to do with that. Patient, the word patient, like you'll say, hey, I got to go see this patient. I'd like to talk to you, but got 2 patients I got to see. Patient literally means to suffer. So patient is from the Latin verb, patior pati, and the past tense is passus, as in the word passion, in the sense of suffering, like that movie Passion of the Christ, in that sense. So when you say, I've got to go see my next patient, you're literally saying, I'm going to see the person that's suffering, because that's what the word means. And this just shows, that it's not, I thought that cardiac arrest was sort of just one of the bad things that can happen if you have an MI, and it's sometimes associated with an MI or with ischemia, but sometimes it's just some random VFib. And here you can see a young person with VFib, who knows why, but had cardiac arrest. The key thing here is immediate good CPR while you wait for the defibrillator, while you move on. And I'll have some insight into that. So there's some VFib. This just shows you what is currently recommended for out of the hospital cardiac arrest is hands-only CPR. And it shows you why in the world that would work. It's shown to be better than trying to do 2-person CPR. It's a different thing, again, when the patient's in the hospital and then you've got the code team and they're getting intubated and all that. But for outpatient cardiac arrest, giving them CPR, hands only, not only gives them cardiac flow, but also gives them some ventilation, as you can see. And again, you can reference all this on the links I give you. Sudden cardiac death or sudden cardiac arrest accounts for 15% to 20% of all deaths. It's extremely common. That's a huge number, that 15% of people who die of sudden cardiac arrest. And it's not just, oh, well, they're weak and they had cancer and then finally their heart stopped. No, it's that they developed, for whatever reason, VTAC or VFib. Now here, full disclosure, and again, I try not to be too much of a showman, but almost 10 years ago, I was walking into the hospital at Trinity, just come back from an outpatient cardiac clinic at Aniana, and it was the middle of the afternoon, and I walked in, X marks the spot where I fell, and VFib arrest. And I was down for 5 minutes. First rhythm was ventricular fibrillation. And I tell you this because it was the middle of the afternoon, the anesthesiologists were out of the OR, and I had the good fortune of having an anesthesiologist who, as you know, are some of the most compulsive physicians there are, just because of what they do minute by minute, do CPR. So I got CPR, as Mel said. I didn't invent therapeutic hypothermia, but 6 months before I had my cardiac arrest, I organized the order set, that's all I did, for Trinity to have a therapeutic hypothermia, where if a patient has a sudden cardiac arrest and they're resuscitated, they're comatose, then what do? Well, you cool them down. And you cool them, at least, it's called managed temperature, targeted temperature management is what it's called now. At the time, we were reducing temperature from 98.6 to 90 degrees for 24 hours and gradually rewarming. Anyway, 6 months after I sent out the order set, I was patient number 5 to get cooled at Trinity. So it's a fun story, but it's true. So, but here's, this is real important because you've heard some bad percentages from the getting off ECMO. The chance of surviving sudden cardiac arrest is pretty low. It's like 3%, and those are 1,000 dots, and 3% of people that have sudden cardiac arrest generally survive, and that's out of hospital. It's maybe 10%, but it's certainly very low. I just happened to be in a hospital, barely. I just walked in, and as again, the main thing is not that I got therapeutic hypothermia, which I needed, but I got good CPR, and I'm going to tell you a little about how you can do that instead of hoping that when you or your patient or your loved ones have a sudden cardiac arrest, they can survive. Even with optimal therapy, you get 30% survival. That means 70% of people, even if everything's set up right now, about 70% will not survive. So it's important as a caregiver, when you deliver CPR, to maintain optimism, because the outlook is pessimistic. Now this is a little saying written by Zhu Yugang. He's a Chinese guy who invented pinyin writing, which is the common pictographs that Chinese use to get over all their different dialects, and he died at age 111. And he's referring to his experience in a concentration camp or a labor camp in China. And those are always bad places, but he found that the people that just gave up, stopped eating, they died. People that maintained some hope in the midst of a hopeless situation would survive. So I throw this in just when you're treating a patient with sudden cardiac arrest, doing everything right as best you can, and not saying, well, gee, this, what's the use? Because that becomes a self-fulfilling prophecy when you get that attitude. And here you go, SEC again. This is the number of people in the United States that die of sudden cardiac arrest every year, 400,000. It's a big problem. So speed is critical. If a patient develops, a patient or a person that you're walking next to passes out, they got sudden cardiac arrest, call 911, but rather than wringing your hands and waiting, starting CPR, even hands only, compression only CPR, is very important, because every minute that goes by that they don't have CPR, their probability of survival diminishes significantly. And there's ventricular fibrillation. Finally, you get a defibrillation, sinus rhythm, ROSC, or return of spontaneous circulation. And that's just showing you that doing high quality CPR makes a difference. But this is key, because when the patient's in ventricular fibrillation, they have no cardiac output. And the only way to give them cardiac output, again, I'm, as Mel told you, overeducated. I've got a PhD in physiology. And one of the simple truths of cardiac output, the equation is cardiac output equals heart rate times stroke volume. That's it. But when you're in ventricular fibrillation, your cardiac output is compression, the quality of the compressions you're getting from whoever's giving you CPR. And the important thing, the rate for compression is about 107 per minute. And the depth of compression is about 4.7 centimeters. And as much as we try to say, well, let's just chant, staying alive, and guess that we're getting 4.7 centimeters, how's that going to work out? It's probably going to vary quite a bit from those important parameters of 107 compressions per minute, relaxing between every compression, and 4.7 centimeters. And again, this is all well known. This has been described for the last several years. Optimal finding 107 compressions, not 80, not 120, but 107. How in the world are you going to keep track of that? And as some of the big studies looking at CPR, this was a big study on resuscitation, and the study was sort of filed up because a lot of the patients never did get good CPR, so they could not really be included in the study because the CPR they got was not up to snuff. And currently, the American Heart Association recommends that you have immediate feedback with your code cards with the devices that you use. This is basically W. Edwards Deming, the reason that a lot of y'all drive Japanese cars, because he rebuilt the industry, the car industry, was the engineer that basically coined the term continuous quality improvement. In other words, you improve the quality of whatever your process is, and you do it the same way every time. You analyze it and you make it better. And there are tools available, and I would urge you, wherever you work, to ask about what kind of code cards are being used. Do they give feedback with an accelerometer like everybody's got on their iPhone or Android, and voice feedback saying push harder, push faster, don't lean, or whatever the appropriate thing is, rather than the current hey, looks like you need to, somebody observing and trying to guess 107 compressions a minute or guess 4.7 centimeters compression is have feedback from something built into the code card. Anyway, and I didn't make this statement up, but I'm saying it again because I gave the last talk I gave was on CQI of CPR, continuous quality improvement of CPR. And there you can read all about it on that cardiocerebral webpage. Again, cardiocerebral, because often you can get the heart back, and y'all are probably involved in codes, and often you get a return of spontaneous circulation, but again, if you've got a patient who's got severe neurologic damage, you've lost a lot of ground. It would have been much better to not to have had that. Okay, just a quick jump, and it's almost through, talking about the vaccines. That there's this big hubbub of, was it too fast, and what's this? The whole concept of delivering messenger RNA in a lipid, some sort of lipid vesicle, having it inside, having a cell produce a particular protein that messenger RNA is programmed to produce, that's been going on for 25 or 30 years. It just so happened that the need was great to quickly produce vaccines, and they used this technology that had been pretty well developed. And this, just talking about some awards that people got for the development since the 1990s of these delivery systems for mRNA. And you know about the coronavirus vaccine. And that's basically a snapshot of how it works. Inject a lipid vesicle that has messenger RNA, take it up by cells. The cells express not the virus, but the spike protein. The spike protein is recognized by the immune system. The immune system makes antibodies to that spike protein. If they ever see it again, they'll attack it. And if it happens to be on the surface of a coronavirus, they'll attack that. And so that's sort of how it works. But it wasn't something just dreamed up starting in December of 2019 or January of 2020. It was just used as a technology that was just getting ready to go. And that just shows it again. I'd encourage you to, yourselves, your family members, your patients, the vaccine, masks, distancing, and vaccines, those are the three things we've got. And again, we're just in the beginning of chapter 2 of this COVID-19 story. And that may be a little tough. Terrible beauty is born. Anyway, there we are. That's the end. Thanks for what y'all did.